ladies and gentlemen. And at the outset, I would take this opportunity to thank our mentor, Dr. Alok Sir, for being behind our back and helping us develop something which I think has gone on to develop the community of practice of what I call as the community otorhinolaryngologist. When we set up on this journey much before COVID, we didn't know COVID was behind our back. We decided we met for a number of meetings together, all of us together, and we thought on the most significant points which need to be brought to notice to a community healthcare worker who is sitting there. But, ladies and gentlemen, I would like to take all of you back to 2020. 2020 is the year which had the set in of COVID 19 for our country. And it changed everything for us. And what did it change? Well, I think it changed the basic human mankind. It changed the way human mechanics work. What it has changed is, interestingly, in the Indian population, we have a rise of diabetes mellitus shooting up to 2.3 times. Not only that, there has been a change in the way our immune systems are working. Something which we thought was not so common will become more common now. So, this, ladies and gentlemen, we highlight again, is something we had developed pre COVID. And now, as we set on to discuss it now in 2026, we at the team of ENT STWs will like to bring to your notice how this can help us to treat the next space infections in 2026. Please change the slide. Also, as we move ahead, the next slide, please. Also, as we move ahead, we have to understand that with the COVID advent, there is something that all of us agree upon. And that is that it is not about a single profession left to treat ENT diseases. We are now working as a team, which we call as an interprofessional team. We are working with a community of practice, and we are marching ahead to the concept of patient safety, not only perceived by doctors, not only perceived by healthcare professionals, but now patient safety is also the responsibility of the most important team member here, friends, and that is the patient himself or herself. You can have a team member being there with you when you have empowered that team member. So, how do you decide to use of these STWs beautifully designed for us by the government, not only in our presentations as a part of the descriptive layouts, infographics, in within our department, outside our department, community-based activities. Not only that, something interesting we did. We celebrate the Patient Safety Week every year in the month of September, and that is when, in the Department of ENT, we put up these STWs as well. It is important for the patient to know as well what could be the predisposing factors if the patient himself or herself can play a role in the early diagnosis, prevention, and treatment. So that's where the role of STWs come in play in a much larger preview. So with this background, we come to the basic concept of the neck space infections. We need to talk about a few things which our friends are with us in online. We've used the word rapidly progressive, which means this is something you have to work with the clock ticking. This is not something that we miss the signs on. These are bacterial infections which spread along facial planes. Now, when they spread along facial planes, the facial planes within the head and neck region are very well communicated, which means if you have a patient with a drop of immunity, goes on to develop sore throat, goes on to develop difficulty in swallowing, goes on to develop a peritonsillar abscess, can rapidly develop into a parapharyngeal abscess as well. What you need to see is these are rapid, they are progressive, and they need to be treated with utmost urgency, else it could be fatal. Ladies and gentlemen, mark the last line, which I think is an absolute golden line which says most of them, or majority of them, could be secondary to dental infection. That please make sure if you have a dental infection, it is treated by a dental clinic. It cannot be treated over the counter. It cannot be treated by a non qualified person. Dental infections need immediate care and supervised care to prevent developing into a head and neck space infection. The next slide, please. Okay, now the presentations, as I have already talked about, they could be varied, which means to begin with, it could be something presenting to you with, let's say, a 24-year-old male who has presented to you with a swelling in the region of the submandibular area. Predisposing factors could be when you take history from the attender, you understand that the patient had a preceding dental infection, went on for an extraction, thereafter developed the infection. A. All these abscesses, I feel, I always mark themselves for myself when I walk through the OPDs. How does a head and neck space infection stand out to us? It stands out to us because the patient will give you a sick look. It will stand out to you because the patient may have been dehydrated because of inability to swallow. It may stand out to you with, of course, the patient being febrile. It may stand out to you because the patient could actually be on a stretcher. So this would be one presentation, Ludwig's angina. Second, which is common, is a peritonsillar abscess or something as common starting as peritonsillitis, which means again immunity is lower. A simple tonsillar infection goes on to develop into a peritonsillitis, predisposing factors which we will be covering. But I think the most common is, I think self-dispensing of medications as well. So we start with one antibiotic, going on to another antibiotic, and by the time it reaches the ENT surgeon, it has already developed into a peritonsillar abscess. The third, which could be less commonly seen earlier to COVID, not now. Yes, you do have presentations of parapharyngeal abscess coming to you and retropharyngeal abscesses, which could be either chronic or it could be acute. The next slide, please. Okay. Now, when I talk to our the young ENT surgeons who could be the postgraduates, we have the team of interns, we have the team of MBBS students. So the first thing that you start telling them is what are you supposed to look out for? So if there is a swelling, there has been an acute onset, one, there has been pain, there has been, most importantly, is that patient will have fever, malaise, and trismus. So if you're looking at something like Ludwig's angina, you know that the patient will present to you with a swelling in the submandibular region. It will be woody in nature. It will have trismus. Patient will have fever. And there you are in an alert that yes. But not only that, why is it that certain patients will go on to develop abscesses? Have you thought about it? If you look at an ENT OPD, let's say we are seeing about 100 patients in a common hospital in India, how many of them would actually abscesses be? So I think maybe in not the summer months, the months that we are in, I would say I would see an abscess maybe twice a week. During the months of summers where I feel I get more abscesses, why isn't the most common presentation? The reason is that there are certain predisposing factors. Before I move to that, the extension is markedly important. All abscesses, ladies and gentlemen, regard head and neck space infections as a one single entity. They can extend, they can go to the parotid region, they can go to the visceral region, they can spread inferiorly to the anterior mediastinum and posteriorly along the prevertebral space, which means a peritonsillar abscess can go on to develop a parapharyngeal abscess. And we know by our anatomy background that this goes up to the level of the sternum. However, if this extends to develop into a retropharyngeal abscess, it can go up to along the prevertebral space right down. So these infections can spread rapidly. And as you see the spread into the mediastinum and right down, you understand how this infection, a simple dental extraction, can be fatal. The next slide, please. Okay. Why is history important? History is important, as I said. Why did I mention the rise of diabetes mellitus? For a number of reasons. Diabetes mellitus does predispose you to infection if it is not well controlled. Whether you're looking at the rural population, urban population, or a mixed population, these factors are extremely important. There could be an underlying HIV infection. It cannot be treated as a taboo anymore, agranulocytosis, or immunosuppressive agents, which means you have to take a detailed history to understand why did the patient move from a normal tonsillitis, peritonsillitis, to develop into a peritonsillar abscess or maybe a parapharyngeal abscess. The next slide, please. Okay. Once the patient has presented to you, now I will now take you back from your OPDs again to a PHC center or a CHC center within your own city. Looking at the PHC, I'm taking you away, say, 200 kilometers down from Lucknow. I'm based in Lucknow, so I'm taking you down there. Now, there is another point I would like to bring forward, which we did not have at that time, and that was the implementation of the competency based medical education, where we tend to bring out an Indian medical graduate. We tell him that at the end of the 5 years, you go on to develop a C2L2P who you represent as an Indian medical graduate and who has to function at the PHC. Ladies and gentlemen, he's not sitting in Lucknow, he's sitting 200 kilometers away from Lucknow. And you have to prepare him based on this standard treatment workflow to treat a patient, diagnose a patient, and notice, identify the red flags. So, as you start, the first thing which you are, I think, sharing with your mentee here is, which is the rule of the thumb, is airway assessment. If you find that the patient is having respiratory distress, is important. As I said, your patient could have difficulty in deglutition, which means the patient would now be dehydrated because the patient is not able to swallow. You monitor signs, you look for heart rate, respiratory rate, signs of sepsis and septic shock. Not only that, as much as your mouth opening is allowing, you're looking for condition of teeth, looking at the floor of mouth for a bulge. Go on still down to the oropharyngeal examination. You look for the tonsils, you look for the inflammation, you look for a bulging tonsil, you look for a bulging uvula if you find. You come to the neck, you examine the lymph nodes, abscess, subcutaneous crepitus. And if you're having any cranial nerve palsies which are setting in. The next slide, please. Now, that was a mental record that you have developed, and you know that if the patient is having a red flag sign, which means number one, breathing difficulty, difficulty in swallowing, neck stiffness, subcutaneous crepitus, skin discoloration, toxemia, lower cranial nerve palsy, or mediastinal extensions, these are red flag signs, which means patient presented to you at the primary healthcare center, you have been able to take a history, you've been able to make a diagnosis. Once you have made the diagnosis, you know exactly when the patient has to be referred to the next level based on these red flag signs. The next slide, please. Okay. A point which I think most of my undergraduates ask me is that I tell them that develop a frame to treat at the a PHC. So they tell me, I said, ma'am, how are you supposed to imagine that? So I tell them that it is important for you to imagine yourself at a PHC and imagine what are the resources you have, which means sitting at a PHC, our IMG is going to be dependent on the STW based on history and examination because you have a limitation of resources. Once you know you have the red flag signs, you have sent to the next level, you would be carrying out imaging, which could be either a contrast enhanced CT scan, and of course, there would be lateral x ray neck or an ultrasound neck. You have to carry out blood tests, which could be in the form of a TLC, a DLC, to see what is if your patient, if you know, is going into a systemic failure, you definitely look for the urea, creatinine, the blood sugar. And if you think your abscess is there, you're able to do the gram staining to develop and to understand what would be your line of management be. The next slide, please. The next slide, please. It's important that we have not gone into many details beyond the exact infographic of the particular draft that we have, keeping in mind that that is the draft which is shared with everybody, and we stick to the draft, except for the fact we raise alarm that there could be more number of cases, there could be greater number of predisposing factors which are there. Definitely at the PHC starting, if you think that there is a compromise to the airway, you can consider doing a tracheostomy. Ladies and gentlemen, I'm in between linking to curriculum as well. That's why we understand the importance of the certifiable skills. Within ENT, we have anterior nasal packing and otoscopy, which my friend Prem has totally outlined why it is important for us to be able to do a otoscopy at the level of an IMG. Not only that, it is important to perform an anterior nasal packing, which again Prem will be covering. So you've been able to do a tracheostomy, of course, be able to establish an IV access, and if required, you are transferring for surgical drainage. Next slide, please. Can you change this? Thank you so much. Now, the patient has been referred, reaches a district hospital. Of course, you have to closely monitor the patient. Besides having done the airway management, besides having corrected the fluid and electrolyte, you have done an incision drainage and you've given the necessary antibiotics based on the indication. Next slide, please. Thank you. Now, these are some important points which we put across for the indications for incision and drainage, which could be an abscess. There has been no response to antibiotics over 48 to 72 hours. Deterioration despite antibiotics. I'd like to stop here and put across a thought to everybody, which I think all of us understand. I think, ladies and gentlemen, there has been a marked change in the mental frame for all of us sitting here. The reason being, COVID has scared us. COVID has told us to be better prepared. Earlier, we could wait for 3 days and start an antibiotic. Now, for a common infection, we start antibiotics. It's very much possible now that your patient may not respond to antibiotics. There could be a deterioration despite antibiotics after 24 hours, or we can have other factors which could range from airway compromise or spread to the mediastinum or vascular complications like venous thrombosis. Next slide, please. Okay, the next slide. I'm skipping up this because we can come right away, I think, to the references. The next slide, please. Okay, these were the references which were shared by us. We've tried to keep them as relevant as possible because these are references which we kept as a fundamental. We leave you with the thought is to know the exact symptoms and signs to diagnose right at the PHC, to know where you have to refer, and once you have referred, what should the exact management be. Before I conclude, I have my extreme acknowledgements to the entire team of ICMR for their constant help. Each of our members of STW, of course, Alok sir, who has led us, Anupam sir, Prasad sir, Dr. Ramesh, Dr. Prem, thank you so much for always being besides each other so we can take this forward. Thank you, ladies and gentlemen. Have a wonderful day.